In this lecture, we're going to discuss the skin manifestations of systemic diseases. And skin lesions are seen with many internal or systemic disorders, and the skin lesions are often the presenting feature. Now, the skin disease itself may not be very important. However, um, it's important to recognize it and to recognize that this lesion could be associated with underlying internal disease. So I'll discuss several entities that could have skin manifestations. And we'll start with hereditary hemorrhagic telangiectasia, also called Osler-Weber-Rendu syndrome. And this is a disorder that's inherited as autosomal dominant. And they have skin, mucous membrane, as well as gastrointestinal telangiectasias, which are dilated vessels, as well as arteriovenous malformations. And in addition, they can also have lung, liver, and central nervous system lesions. So in the skin and oral mucosa, what you're going to see are those red spots, which are telangiectasias. Sometimes you can see small arteriovenous malformations. So in the on the lips and the buccal mucosa, on the tongue, as well as on the fingers. The most common presentation of hereditary hemorrhagic telangiectasia is recurrent epistaxis, which is nosebleed. So when you see someone with the skin lesions, and automatically we ask, do you have nosebleed? Because this then could sway you in the direction of the diagnosis. And in addition to nosebleeds, they can have hemorrhage at any site where those arteriovenous malformations and telangiectatic vessels are present, so in the lungs, in the liver, brain, eye, and GI tract. So important to recognize this syndrome, and the presentation again could be just those tiny little red dots on the lips and on the fingers. Now the next syndrome that I'll discuss is Ehlers-Danlos syndrome, and this is a connective tissue disorder which is inherited again. It has several subtypes, but the basic defect is in collagen. So collagen is defective, and this is what leads to the signs and symptoms. They can also have a defect in the extracellular matrix, processing enzymes, and tenascin X. Now, features include some joint hypermobility, scoliosis, ocular changes, and they also have significant risk of ruptures of organs because the collagen is defective, so arterial, intestinal, or uterine rupture. Now, these are the typical skin features that you see in Ehlers-Danlos. So they have a hyperextensible skin. Okay, and you can see that you can really stretch the skin, and they can touch the tip of their nose with the tongue. They bruise very easily, and they don't heal well. Okay, so they have poor wound healing. So you will see lots of scars on those people's skin, especially on the knees, areas that got traumatized easily. Their joints are hypermobile. They also are painful, and they can have joint dislocation. If you try to do any of those moves, you probably won't be able to. In addition to the skin and joints, they can have blue sclera, mitral valve prolapse, aneurysms, aortic dissection, hernias, gastrointestinal perforation, and bleeding, as I mentioned. So next entity, also a connective tissue disorder, involves a defect in elastic fibers, and it's pseudoxanthoma elasticum. It could be inherited or acquired. Now, pseudoxanthoma because the lesions are yellowish, so they look like xanthomas, and elasticum because it's the elastic fibers that are affected. And the elastic fibers are clumped, fragmented, and calcified. And wherever you have elastic fibers, most of these will be affected. So in the skin, in the eyes, in the heart, gastrointestinal tract, so on. And they have mutations in the ABCC6 gene. So When calcification occurs in the elastic fibers and the arteries, so in the medium-sized artery in the walls, because of the calcification, you will get narrowing of the arterial lumen. And when you get narrowing of the lumen, then this could lead to hypertension, to stroke, angina, myocardial infarction, etc. They can have retinal hemorrhages, gastrointestinal hemorrhage also because of the weak elastic fibers. So in PXE, the papules are yellowish. They're very small, most commonly on the neck, on flexural areas, so like the armpits, the antecubital area. And the skin really looks cobblestoned, a bit like plucked chicken skin. So they're relatively subtle changes. And they also have redundant skin folds in the flexures. Now, the skin changes usually appear in the inherited form during childhood, but they may not be noticed, and one can think of them as a normal skin. So most often diagnosis is delayed until maybe the third or fourth decade of life when a serious systemic complication develops. So the importance of recognizing those very subtle, really, skin changes to be able to prevent later systemic complications. So moving to different entities now. Uh, vasculitis. Vasculitis is something you're going to encounter a lot. And a very common form of vasculitis is henochine line purpura that you can see more commonly in kids. And in vasculitis, the purpura is when there is extravasation of red blood cells, okay, out of the blood vessels into the skin. So they will present with a purpuric rash, and it's palpable. So it's not, when you touch those purpuric lesions, you can feel something. They're not completely flat, which is very typical of vasculitis. And in addition to those skin changes to the purpura, these with henochine line, they will have abdominal pain, abdominal cramps, hematuria, so blood in the urine from kidney involvement, and they can have arthralgia, arthritis, and it's an IgA mediated vasculitis. Now we move to some skin changes that you see with inflammatory bowel diseases, so namely ulcerative colitis and Crohn's disease. And these have a variety of skin manifestations, so we'll go over them. So the first of these is aphthous ulcers. So aphthous ulcers, or hamu, are extremely common. Most people who have aphthous ulcers do not have IBD. Okay, so you see these in normal people, sometimes triggered by stress, by minor trauma, if one bites certain kinds of food, etc. So aphthous ulcers in general, not every person with aphthous ulcers we're going to investigate for IBD. However, if a person has aphthous ulcers, some GI symptoms, abdominal pain, diarrhea, etc., then one has to be on the lookout for IBD. Another common disease that can cause, of course, aphthous ulcers is Behçet's disease. Now, with Crohn's disease, if you look at the buccal mucosa, you will see cobblestoning. Okay, so when we see this in the buccal mucosa, one has to really look for Crohn's, maybe take a biopsy also to diagnose Crohn's disease. Now, pyoderma gangrenosum, this is a misnomer. As you will see, there are lots of misnomers in dermatology. So it's not an infection. It's not a real pyoderma. Pyoderma normally refers to an infection. Okay, so gangrenosum because they look like gangrenous skin. So it's not an infection. They're painful ulcers that start off as a very small pustules with some erythema around it, and then these lesions enlarge and ulcerate, and the ulcers keep on enlarging. It's also common to see these on sites of trauma, which we call pathergy. So if there has been some minor trauma, the ulcer will develop and will grow. It's important to recognize this entity because one should not do surgery, so one should not debride those lesions. If this were an infection, then maybe the first thing one would like to do is to remove this necrotic tissue surgically. However, in PG, uh, if you debride it, the ulcer is only going to grow bigger. Okay, so very important to recognize that this is not an infection, it's pyoderma gangrenosum, and not for them to have any surgery. And it's more commonly seen with ulcerative colitis, this disorder. So when you have a patient presenting with pyoderma gangrenosum, half of them would be idiopathic. So we look for underlying cause, but we do not find anything. However, in half of them, there will be inflammatory bowel disease, more commonly ulcerative colitis. It can also be associated with rheumatoid arthritis and with paraproteinemia. So we do investigate these patients. And once the ulcers, with treatment, once the ulcers heal, then they will end up with some scarring on the skin. Now, another entity which we see in association, not only, but also in association with inflammatory bowel disease is erythema nodosum. So erythema nodosum is a very common condition, much more than pyoderma gangrenosum. And it's basically a paniculitis, which is an inflammation of the subcutaneous fat. And the patient present with painful erythematous nodules. They're deep on the legs, most commonly. And EN is a reactive process, so it's an inflammation in reaction to something. It could be idiopathic, so sometimes we do not find any underlying cause. However, we commonly see this with strep infection, sore throat, again, inflammatory bowel disease, with sarcoidosis. Certain drugs can cause erythema nodosum, like the oral contraceptives, and pregnancy. So moving on from some of those skin manifestations that you see in inflammatory bowel disease, in addition to in others, I'll just mention sarcoidosis. This is a disorder which is very common, so I'm sure you'll get to see this in your clinical years. So it's a multisystem granulomatous disease. The granulomas are non-caseating, so it's not an infection, again, inflammation. The skin is commonly affected, and in addition to the skin, they can have involvement of the lungs, of the brain, of the heart, lymph nodes, eyes, etc. So we often diagnose sarcoid in the skin. So we take a skin biopsy, which is going to show those typical sarcoidal granulomas. And when we see sarcoid in the skin, we do investigate. So we look for pulmonary involvement, etc. So we do a CT scan, we check the eyes, and some patients with sarcoid will have only lesions in the skin. However, most of them will go on to develop systemic disease. Again, a disorder which could be associated with an underlying GI actually disorder is dermatitis herpetiformis. And these patients present with extremely itchy vesicles and or small blisters. And these most often are on the elbows, on the knees, on the buttocks, sometimes on the scalp, on the hands. And this is a neutrophil mediated disease. You will see IgA deposition at the dermoepidermal junction when you do immunofluorescence. And the importance of recognizing this is that it's associated with celiac disease or gluten-sensitive enteropathy. And most often, when these patients go on a gluten-free diet, this could really control very well their skin lesions. Okay, so now we move to diabetes. And diabetes, as you know, is pretty common, and it has so many complications. So vascular disease, neuropathy, nephropathy, they are predisposed to infections. Now, among the infections are skin infections, and both fungal and bacterial infections are more common in diabetic patients. So candidiasis, so candida, which is a yeast infection, this could be the really presenting sign of diabetes, and it's more commonly seen when the diabetes is uncontrolled. And they could present with different types of candidiasis, and I'll show you some of these. So oral thrush and angular cheilitis, this is due to candida. So you see this whitish pseudomembrane in the buccal mucosa. And if you scrape this and you put it, one of those whitish lesions, and you put it on a slide, you will see the mycelia, the UCD candidiasis. And angular cheilitis, again, it's the same, but involving the angles of the mouth. So when you see a patient with oral thrush, that is not really explained. So the patient wasn't sick, he was not taking antibiotics, etc. Then definitely look for diabetes, or make sure the patient is not diabetic. And if he's diabetic, make sure he's controlled, because he probably is not. Now, another involvement is paronychia. So paronychia is when you get inflammation around the fingernails, and the skin around the fingernail becomes erythematous, and then you can get candida on top of it. And diabetics, again, are more prone to develop balanitis, candidal balanitis, and vulvovaginitis. And also intertrigo, which you see on the skin folds, so under the breast and the armpits and the crural areas. From humidity, you get overgrowth again of candida. So you see those red lesions and those tiny pimples around them, which we call satellite lesions, which are typical of candidiasis. And again, to confirm, we just take a scraping and then look for yeast under the microscope. And there is a peculiar candidal infection that affects the third finger webs. Okay, so you see candida in the third finger web between the ring finger and the middle finger. And when we see this, almost always the patient is diabetic. So again, this is a sign of candidal infection that we see mainly in diabetic patients. So in addition to candida, which is a yeast, diabetics again are prone to develop fungal infections, deep fungal infections with weird organisms, and aggressive fungal infections. And one of these opportunistic infection is mucormycosis. It's a pretty aggressive infection. So you can see it here involving the nose. They look necrotic, like dark. They can have perforation of the nasal septum. Here with involvement of the eye, of the hard palate. So mucormycosis, a pretty aggressive, opportunistic, deep fungal infection that you see in more often in diabetics. Now, bacterial infection also are more common in diabetic patients. So these could be just regular bacteria like Staph aureus, group A strep, causing all the types of infections, so superficial, impetigo, or folliculitis, cellulitis, etc. And in diabetics, they are much more prone to develop complications from these bacterial infections, so like necrotizing fasciitis and gangrene. So one really has to be very aggressive in managing these patients. So this is cellulitis or erysipelas on the leg of a diabetic patient. And whenever you see cellulitis on the legs, always examine the toes of your patient and the toe webs, because most often they have tinea pedis, so they have what we call, it's like athlete's foot, so they have scaling between the toe webs, which is due to a fungus, and then because of the breaks in the skin, this allows the bacteria to enter and then to cause cellulitis in the leg. So always examine the toes and treat, because diabetics will be prone to develop recurrent episodes of cellulitis if you don't treat the fungal infection in the feet. So as I mentioned, diabetics are more prone to develop severe infections, so like necrotizing fasciitis, and this is really an emergency serious infection. It's very rapidly progressing, and when it starts initially, there is barely anything you can see on the skin. So, but the patient complains of severe pain, and then when you examine, you barely see sometimes some redness. Okay, so and then very rapidly, the erythema will increase. They may develop blisters, hemorrhagic blisters, and then because it starts in the fascia and then it goes all the way up, and then you will get those ulcers. And so this is a disease that has to be managed very rapidly. This would need debridement. Okay, unlike, if you remember, I told you about pyoderma gangrenosum, which is sometimes mistaken for this. So this needs debridement. It needs IV antibiotics and so on. And gangrene, which is really the scare of diabetic patients. Okay, from infection and from the vascular occlusion as well. That often leads to amputation of digits or even the foot or leg, etc. Now, again, a peculiar bacterial infection that diabetics are prone to is malignant external otitis. Malignant not because it's cancerous, because it's an aggressive infection. And this is caused by Pseudomonas aeruginosa. And it starts in the outer ear, but then it can rapidly invade the cartilage and then the bone and then go all the way up to the brain. So important to recognize and treat early before getting all the complications. Now, in addition to infections, of course, diabetics are prone to get neuropathic ulcers. So they get ulcerations because they don't feel the pain, ulcers on bony prominences, and these again may be the source of infection, etc. So important to treat these. Now, one entity which we see commonly in diabetics is acanthosis nigricans. Now, acanthosis means thick skin, okay, when the epidermis is thickened, and nigricans because they're dark, they're black. So they feel like velvet, مثل المخمل. So it's a velvety area which is brown black, and you see it most commonly on the posterior and sides of the neck, and in other flexural areas like the armpits, the groin. And when you see acanthosis nigricans, you know that it is a marker of insulin resistance. So you will see it in obese people and diabetics, and also sometimes with other endocrine disorders, with PCOS, etc. And it can also be a paraneoplastic, I'll show you later. So it can also be associated with an underlying cancer. But in obese and diabetic patients, there is a reason. So we do not investigate, except that we keep an eye, we look for diabetes, of course, advise weight loss, etc. So acanthosis nigricans, remember, is a marker of insulin resistance. Okay, now we move to some changes that you see secondary to, in association with heart disease. So xanthomas you see in patients who have hyperlipidemias, and these are inherited, they're familial, and I'll show you some pictures. And of course, these patients are more prone to have coronary artery disease because of the hyperlipidemia. And cholesterol emboli, again, which can have manifestations in the skin. And these are in patients who have CAD. So xanthomas are yellowish, orange, sometimes plaques, sometimes papules. They can be linear, so they can be on the palms, they can be on the elbows, on flexural areas even. Of course, when we see xanthomas, we do investigate, so you have to refer to an endocrinologist and then do the entire lipid screening, etc. Very important to screen these patients, and most often they have really sky-high values of cholesterol, etc. A peculiar type of xanthoma is what we call xanthelasmas. So again, they're those yellowish plaques, very, very common, and you see them on the eyelids, upper and lower eyelids. And when we see this, we do again look for an elevation in cholesterol. Half of these patients will have high cholesterol. It's cholesterol that's deposited, so the yellowish color is due to cholesterol. And a peculiar type of xanthoma is called eruptive xanthoma. So this is a sudden eruption of extensive, multiple small papules over the body. And sometimes one may miss them because they may not be perfectly yellow. So very often eruptive xanthomas look inflammatory. They look a bit red. So one really has to look very closely. And then once you diagnose this, I mean by biopsy usually, these patients have extremely high triglyceride levels, really very high, and often they're diabetic also. So cholesterol emboli, we see this, it's secondary. I mean, these patients have atherosclerosis, so they have an atherosclerotic plaque in their arteries, and depending on where the location is, when you get a piece of this plaque that's dislodged, okay, inside the vessel, then this plaque will be showering emboli, okay, so small pieces will move with the bloodstream and then occlude at some point. It cannot pass through a vessel and then it occludes it. So when they're very tiny emboli, you will see the occlusions on the fingertips, on the toes, and once there is occlusion of the vessel, eventually you're going to get, this bluish black discoloration, and then you may get necrosis of the area. Now, when emboli are larger, then they can lodge in bigger arteries, like in the thighs, in the femoral artery, etc., and then cause again this rapidly progressive black eschar, which is due to the embolus. And if you remember what I showed you before, which is the necrotizing fasciitis, sometimes they really look alike. So cholesterol emboli with this necrosis can really look like necrotizing fasciitis. So it's the history, it's other clinical signs and symptoms. Okay, so we move to a group of connective tissue disorders, autoimmune disorders, and we'll go over lupus, dermatomyositis, and scleroderma. So lupus erythematosus is an autoimmune disease, and it could be localized or systemic in nature. And one thing really to remember on lupus patients is that these patients are extremely photosensitive. So they're very sensitive to the sun. So lupus is a bit of a spectrum. So on the one hand, you have like chronic cutaneous lupus. So these patients have mainly skin disease. There is the subacute, which could have systemic as well, and then there's the acute lupus, and we'll go over every one of those. So starting with acute lupus, which is SLE, which is systemic lupus. In the skin, what we see is a malar rash, which is the typical change in SLE. These patients can also have vasculitis, which is pretty non-specific. We'll discuss also subacute lupus, chronic cutaneous lupus, which includes discoid and lupus paniculatus. So SLE, the typical malar or butterfly rash is this erythema that you see on the nose, on the cheeks, sometimes involving a bit the forehead. These patients are sick. They're extremely photosensitive, so they will also develop this rash when they're in the sun, and they have positive ANA, anti-DNA. They have involvement of the kidneys, the heart, depending on the case, the brain. Okay, so this is SLE. Now, in addition to the malar rash, which is the typical finding, patients with SLE can have vasculitis, which is non-specific, and so it could be on the body, on the extremities, on the hands. And if you look closely, you will see that on the hands, lupus vasculitis tends to spare the joint area. Okay, so if you look at the MCPs, etc., the joint area is relatively spared. This is in contrast to dermatomyositis that I will show you in a while. So it's a clue sometimes just to differentiate between lupus and dermatomyositis. So next is subacute cutaneous lupus. Now, again, this is very photosensitive. Okay, so it will develop on sun-exposed areas, and there are two clinical presentations to SCLE. One of it is annular, and the other is psoriasiform. So psoriasiform because the lesions look like psoriasis, and the annular has, of course, a big differential clinically. It could be, I mean, one has to suspect lupus and take a biopsy because this looks like it could be a fungal infection and other things. And these patients have usually a positive ANA and they have positive anti-Ro autoantibodies. Subacute, I mean, patients who have SCLE, if they have systemic involvement, it's usually mild and they can have joint involvement, but they rarely have severe disease, systemic disease like with SLE. And the lesions, the skin lesions resolve on when we treat them, and they do not scar, they do not leave any scarring. Now, discoid lupus is most commonly purely cutaneous. So most patients with discoid lupus will never develop systemic lupus. So they will only have skin lesions. And their skin lesions are plaques, and then they progress and evolve with scarring. I mean, they will eventually lead to scarring in the skin. And very commonly, you have pigment. And this is discoid, again, discoid lupus. Uh, it's a cause of scarring alopecia. So when we see hair loss on the scalp, which is scarring, where the hair follicles have been completely eradicated and there is no way the hair is going to regrow, discoid lupus is always in the differential. Okay, so you see the skin, which is like depigmented, completely scarred, and on the other picture you see the brownish discoloration. So discoid lupus, although it's in general a cutaneous only disease, however, it can really cause lots of scarring, disfiguration. Um, and lupus can also involve the fat, and it causes loss of fat, and we refer to this as lupus paniculitis or lupus profundus. So this is lupus involving this subcutaneous tissue, and secondary to the inflammation, there will be loss of fat, and you will see those, depressions in the skin. Again, patients with lupus paniculitis, half of them may go on to have to develop systemic lupus, but again, usually not severe. And finally, neonatal lupus. So some infants are born to mothers who carry the anti-Ro antibodies, and when they're born, they can develop those skin lesions, and the skin lesions in neonatal lupus look like subacute cutaneous LE. Okay, so they look like SCLE. So they're often psoriasiform or annular. And the importance of recognizing this entity is that they can have cardiac involvement with heart block. Okay, so important to recognize those children, to diagnose that this is lupus, and then to check their hearts, basically. So next is dermatomyositis. So dermatomyositis, again, another autoimmune disease. And it's characterized by proximal myositis and typical skin changes. So again, like lupus, patients with dermatomyositis are extremely photosensitive. So we always tell these patients, I mean them and the lupus patients, to avoid the sun, to use sunscreen, because the sun can really exacerbate their disease. Okay, so again, lupus and dermatomyositis, both very photosensitive disorders. And I'll go over some of the skin findings in dermatomyositis. So one typical skin sign that they have is what we call the heliotrope rash. So it's purplish erythematous patches on the most commonly on the eyelids, sometimes also on the cheeks and on the forehead, but the eyelids are a very typical site. And heliotrope refers to the flower and the color of the flower. And sometimes, in addition to the discoloration, to this erythema, you will have edema or swelling also of the eyelids. So this is typical of dermatomyositis, the heliotrope rash. And they can have poikiloderma. Poikiloderma refers to um, telangiectasias with pigmentary changes and atrophy of the skin. Okay, and if you look at at this man, you will see this erythema and some pigmentation involving the chest area, the upper back, neck, and we refer to this as the shawl sign. Okay, so it's like where one puts a shawl. So the shawl sign, which is again typical of dermatomyositis, and if you look, you can also see the heliotrope rash and the edema on the eyelids. Now, typical lesions of dermatomyositis are what we call Gottron's papules, and these are those purplish, erythematous, small papules you'll see on the dorsal hands, on the elbows sometimes. And in dermatomyositis, again, in contrast to lupus, these commonly occur on the joints. Okay, so you will see them on the joint area, in contrast to lupus, which was where the vasculitis usually spares the joints. So Gottron's papules, typical of dermatomyositis. And if you look at the nail folds, so the skin just before the nail plate, in dermatomyositis, you will see dilated capillaries. So you see those tiny red lines on the nail folds. And so when you have a patient presenting with, okay, those tiny purplish lesions on the fingers, maybe a heliotrope rash, some erythema, you look at the nail area and you see that there are dilated vessels, and if you ask about to be able to try to diagnose it, you will ask about muscle weakness. So you ask the patient, are you able to lift your arm? Are you able to brush, for example, your hair, or do you really feel weakness? So these are clues to the diagnosis of dermatomyositis. Okay, so and one can really look closely at those at the nail fold area, and you see those capillary loops that are dilated. And this is due to microvascular abnormalities in dermatomyositis. Now there's a juvenile type of dermatomyositis, and in the juvenile type, these patients often get calcinosis, and it's really, I mean, this is quite a tough thing to treat. Those calcifications are often big. They can discharge, they can open up, ulcerate, and then discharge. I mean, it's like chalk, but the top shur, and they ooze those calcified material. So calcinosis you see more commonly in juvenile dermatomyositis, so in younger people. So patients with dermatomyositis have a higher risk of malignancy, mostly adenocarcinomas. And so when a patient with dermatomyositis is diagnosed, what we normally do is a really detailed review of systems, a very good physical exam, and it's very important to do an age-appropriate screening. So to look for an underlying malignancy. So depending on whether it's a man or a woman, you may look for, lung CA, colon cancer, in women, ovarian, breast CA. So dermatomyositis can be a paraneoplastic disease, and they do have a higher risk of malignancy. So always be on the lookout for that. And the next autoimmune disease we'll discuss is scleroderma. So in scleroderma, we have a localized form, which we refer to as morphia, which is purely in the skin. So these patients have only skin involvement, no systemic disease whatsoever. And there is systemic sclerosis. And in systemic sclerosis, there is the limited systemic sclerosis, which is referred to as CREST, and the diffuse with involvement of the skin and internal organs. So in morphia, of course, in scleroderma in general, there is inflammation that starts in the fat and in the dermis, and then this will end up with sclerosis, so thickening of the connective tissue of collagen, and they end up with like scars basically in the skin. So this is morphia. It's usually asymmetric, so not, I mean, you don't have to have symmetric lesions on the body, and you end up with this indurated sclerotic like scarred area which is bound down to the skin. And with morphia we often have also some pigmentary changes, so the lesions could look purplish, brownish, sometimes depigmented, even sometimes they look like vitiligo. But you have to feel the skin to feel the induration. So this is morphia, and as I said, morphia is purely in the skin. And morphia can also be linear. So it could involve just one, part of one extremity. It could be linear on the forehead and on the scalp, and this is referred to as cul-de-sac morphia. And you will see this depression, and on the scalp, the area involved could have loss again, alopecia, so loss of the hair in that area. Now, systemic sclerosis. So we have the limited cutaneous systemic sclerosis or CREST, and the changes here are limited usually to fingers and the hands and the face, and they have those typical findings with telangiectasias in CREST. And the diffuse cutaneous systemic sclerosis, where the lesion starts in the fingers and hand, but eventually they extend to the forearms, to the face, the trunk, the lower extremities. So I'll show you some of the skin changes that we see in scleroderma, in addition to the skin sclerosis and the tightening of the skin. So Raynaud's phenomenon is common. And in Raynaud's, you have the color change from white to blue to red, and of course, it's in response to cold and sometimes to emotional stress. So in this slide, you can see the typical skin changes. So namely on the face, the beaked nose, there is tightening of the mouth with a very tight opening. You will see furrowing around the mouth as well. And because of the extensive tightening and hardening of the hands and the fingers, you will see sclerodactyly, so the hands are a bit claw-like. They're unable to really move their fingers, and sometimes because of the extreme tightening and the vascular involvement, you may get amputation of the distal tips of the fingers. Again, the necrosis causing ulcerations, and then you can have loss of the fingertips secondary to the necrosis. You can also see some calcification in the finger, those nodules that occur. You can see the telangiectasias on the face, on the fingertips, as you see in CREST. And like with the dermatomyositis, again, patients with scleroderma will have microvascular damage, and you can see this in the nail folds. You can see the dilated, tortuous capillaries. And these are often early markers of systemic sclerosis. Now, finally, we move on to skin signs that you see in association with internal malignancy. And we'll go over two groups, so the paraneoplastic syndromes or manifestations and some metastatic lesions. Now, paraneoplastic syndromes, the cause of the paraneoplastic syndrome is a cancer somewhere in the body. And the paraneoplastic manifestation could be the first manifestation of an underlying cancer. Now, the lesions themselves, so what you see as a paraneoplastic, for example, skin lesion, the skin lesions themselves are not malignant. So this is not, the lesions are not due or are not cancers themselves, okay? It's not metastasis from the cancer. It's a manifestation, so there are signs that there is an underlying cancer, but the skin lesions themselves are not malignant. And the importance of diagnosing these or recognizing them is that one, I mean, this could be the first sign of an underlying malignancy, so one has to look for a malignancy. Now, a very common paraneoplastic sign is pruritus, itching. So these patients have generalized severe itching, and then you examine them, all you see are excoriations or scratch marks. You don't see any primary, I mean, there is no skin disease to explain the itching, there is no scabies, of course we look for all of these. So it's just their skin is extremely itchy. And when you see generalized pruritus that is unexplained, then you have to look. I mean, one of the causes could be an underlying malignancy. And among the most common is Hodgkin's lymphoma. Okay, so we do look for an underlying tumor. Now, necrolytic migratory erythema, this is a peculiar paraneoplastic manifestation, and these patients always have an underlying glucagonoma, which is an alpha cell tumor of the pancreas. Now, in the skin, what you will see are those red lesions, so red patches with some crusting, some peeling, and most often they're around the orifices, so around the mouth, the perianal area, etc. So the skin is just red and scaly. Of course, in these patients, we also look for, I mean, we have to rule out a vitamin or specifically zinc deficiency, because zinc deficiency can present with exactly the same picture. But once this is ruled out, then you have to look for a glucagonoma. Now, acanthosis nigricans that we discussed before in association with insulin resistance, it can also be a paraneoplastic manifestation. And now, how do we differentiate? Now, acanthosis nigricans is extremely common. I mean, a lot of obese patients, people will have acanthosis nigricans, diabetics. So not every time we see acanthosis nigricans, we're going to look for an underlying tumor. However, if you have a rapid onset of acanthosis nigricans, so someone who suddenly develops this brownish, thick skin on the crural areas where it's severe, it's very itchy, and it's present in some weird areas like the lips where we don't normally see acanthosis nigricans, then we have to suspect that this is what we call malignant acanthosis nigricans, so acanthosis nigricans due to an underlying cancer. And most commonly, it's associated with an adenocarcinoma of the stomach. So remember, a rapid onset, itchy, very extensive acanthosis nigricans, these are the clues to look for an underlying malignancy. And sometimes also an association is what we call the laissez-trela sign. Now, laissez-trela is it's the sudden eruption of numerous benign seborrheic keratoses. Now, seborrheic keratoses normally we see in adults and older people. They're benign brownish lesions. Most people will develop some seborrheic keratoses. So, but if someone suddenly develops, like an eruption of seborrheic keratosis, and the patient has acanthosis nigricans, etc., then of course we have to look for an underlying malignancy. And as I mentioned, it's most commonly an adenocarcinoma of the stomach. Now, acquired ichthyosis. Ichthyosis is, I mean, usually an inherited disorder that we see in infants and kids. However, ichthyosis can be acquired. And ichthyosis, they have those fish-like scales on the body. So in an adult who suddenly developed ichthyosis on the skin, then one has to look for an underlying cause. And most often it's an underlying tumor, and this could be a lymphoma, again, very common, or other types of cancers. And in addition to cancers, we also see acquired ichthyosis with HIV also. Now, another paraneoplastic manifestation is acquired lanugo hair. Lanugo hair is the hair that's present in utero, so it's this very fine, thin, whitish, depigmented hair, which is shed normally in utero. And then, so if somebody, an adult, develops, acquires lanugo hair, this is almost always associated with an underlying malignancy. So always look for an underlying tumor. Most commonly, it's lung CA. Now, deposition of a certain material can also, reflect an underlying tumor. For example, jaundice. Now, in jaundice, you have bilirubin that deposits in the skin, and so jaundice could be due to several things. It could be associated with viral hepatitis, but it could also be associated with an underlying malignancy like pancreatic carcinoma, biliary carcinoma. Melanosis, where you have lots of melanin, which is secreted by a malignant melanoma depositing in the skin. Hemochromatosis, where you have iron, and then this could be associated with an underlying hepatocellular carcinoma. And finally, amyloidosis, systemic amyloid, which could also be associated with an underlying multiple myeloma. So this is a patient with a malignant melanoma, metastatic, and the tumor was secreting a lot of melanin. I mean, this is not a common thing, but someone who develops this darkening of the skin color, okay, where the patient originally was very fair-skinned, and so someone who develops this darkening of the skin, one has to look for an underlying melanoma, which is secreting a lot of melanin. And amyloidosis, which could be associated with multiple myeloma. So in the skin, systemic amyloid could be diagnosed. There are some clues to diagnosing it. There is what we call pinch purpura. So these have, because of the amyloid deposits around the blood vessels are extremely fragile, so they bruise easily. They will have purpura or bruising very easily and very commonly around the eyelids, and we call this pinch purpura. And so this is a sign of systemic amyloidosis. And macroglossia, so these patients with systemic amyloid have a big tongue. And these, again, systemic amyloid may be associated with an underlying multiple myeloma. So these are just, it's just to show you that some skin clue signs should just point you to look for something else. So if you see pinch purpura on the eyelid, this has to make you suspect systemic amyloidosis, etc., and then one has to work up for myeloma. Now, finally, I'll show you some skin metastases. So, skin metastases is completely different from the paraneoplastic in that you have cancer cells that have metastasized from the original tumor into the skin. Okay. And they will reach the skin either by direct invasion. Okay, so for example, when you have breast cancer, the malignant cells can directly invade the overlying skin, or of course through the blood or through the lymphatic vessels. Now, internal cancers don't often metastasize to the skin, so it's about 0.7 to up to 10% of internal malignancies will metastasize to the skin. Now, breast cancer is one of the most common cancers. This we see a lot, skin mets from an underlying breast cancer, and they can have a variety of presentations. So it could be inflammatory, like you see on the left. So sometimes it could just be redness on the skin. So you have to suspect it, take a biopsy to show the cancerous cells in the skin. It could be nodules, etc. So different presentations of breast cancer from metastasis and direct involvement of the skin. Sister Mary Joseph's nodule is a metastatic nodule that occurs in the umbilical area. And most commonly, I mean, it is, of course, there it's cancerous and most commonly associated with an underlying pancreatic, ovarian, colon, etc. cancer. So from the area. And skin metastasis can really look like anything. Okay, so one has to have a high index of suspicion. So it could be one nodule, it could be multiple lesions. So anything suspicious that you cannot really fit with a a known skin disease, biopsy. I mean, we biopsy a lot the skin because it's very easy, very accessible, and this will help you to make a diagnosis. Now there are certain types of cancers that have a peculiar site of metastasis. For example, renal cell carcinoma typically metastasizes to the scalp, to the skin of the head. Okay, so when we see nodules on the scalp that are, and we're suspicious of a malignancy, most often we know that this is going to turn out to be a renal cell carcinoma. I'm gonna end up by showing you an interesting case of an intravascular lymphoma. So this patient presented to us with 3 months history of generalized edema, fatigue, weakness, weight loss, and he had those skin lesions that consisted mainly of dilated vessels, so telangiectasias that looked like spider angiomas actually. He had pitting edema and he also had hepatosplenomegaly. And we really couldn't figure out a cause for those extensive dilated vessels. So we did a skin biopsy, and there was no diagnosis yet on this patient. So we did a skin biopsy from those dilated vessels. And what we found were malignant B cells, B lymphocytes that were invading those blood vessels and that led to those telangiectasias. So this was an intravascular B cell lymphoma with this very weird and unique presentation.